Combination therapy in hypertension. A 58-year-old man has been taking amlodipine for 3 months, yet his blood pressure remains 168 over 98 millimeters of mercury. Should you double the dose of amlodipine, add a second drug, or switch to another medicine altogether? This is one of the most common clinical decisions in hypertension management. The answer isn't simply add more medicine. It's about choosing the right combination. When selected correctly, two drugs can work together to produce greater blood pressure reduction, fewer adverse effects, and better patient compliance than high-dose monotherapy. In this video, we'll explore the rationale behind combination therapy, the most commonly recommended drug combinations, and the combinations that should never be prescribed together. Why combine antihypertensives? Now let's answer an important clinical question. Why do we combine antihypertensive drugs instead of simply increasing the dose of a single drug? There are 4 major reasons. The first is synergistic efficacy. When two drugs with different mechanisms of action are combined, they lower blood pressure far more effectively than simply doubling the dose of a single agent. This provides greater blood pressure reduction with a better therapeutic response. The second is compensatory blockade. Many antihypertensive drugs trigger counter-regulatory or reflex responses that reduce their effectiveness. For example, diuretics activate the renin-angiotensin system, which tends to increase blood pressure. However, when an ACEI inhibitor is added, it neutralizes this diuretic-induced renin activation, making the combination more effective than either drug alone. The third advantage is better tolerability. Using low doses of two drugs reduces the risk of dose-dependent side effects compared with high-dose monotherapy. A classic example is combining an ACEI inhibitor or ARB with a calcium channel blocker, where the ACEI inhibitor or ARB helps reduce the peripheral edema commonly caused by calcium channel blockers. Finally, combination therapy provides improved adherence. Single pill combinations reduce the patient's pill burden, making treatment simpler and improving long-term patient compliance. ACEI inhibitors plus calcium channel blockers. This is a preferred first-line combination for patients who require two-drug therapy. One of its major key benefits is the superior reduction of cardiovascular events in high-risk patients. Clinical trials have shown that this combination not only lowers blood pressure effectively, but also reduces the risk of major cardiovascular complications such as myocardial infarction and stroke. Another important advantage is improved tolerability. Calcium channel blockers commonly cause peripheral edema due to preferential arteriolar dilatation. However, adding an ACEI inhibitor dilates the venous circulation, lowering capillary hydrostatic pressure and thereby reducing CCB-induced peripheral edema. Because of these advantages, the ACEI inhibitor CCB combination is highly recommended for patients with established cardiovascular disease or diabetes, where both effective blood pressure control and long-term cardiovascular protection are important treatment goals. Angiotensin receptor blockers plus calcium channel blockers. This combination is particularly valued for its excellent tolerability profile while still providing effective blood pressure reduction. Let's understand how the two drugs complement each other. The ARB blocks the angiotensin II receptor, thereby reducing vasoconstriction. At the same time, the calcium channel blocker blocks calcium channels, causing relaxation of arterial smooth muscle. Together, these complementary mechanisms produce dual vasodilation, resulting in superior blood pressure control. An important advantage of this combination is its excellent tolerability. Since ARBs do not cause the dry cough or angioedema associated with ACE inhibitors, the ARB-CCB combination is an ideal alternative for patients who cannot tolerate ACE inhibitors. Angiotensin receptor blockers or ACE inhibitors plus diuretic. This combination is considered highly effective because the two drugs lower blood pressure through complementary mechanisms. The diuretic reduces blood pressure by promoting sodium and water excretion, leading to volume reduction, while the ACE inhibitor or ARB suppresses the renin-angiotensin-aldosterone system, providing neurohormonal blockade. Together, they produce a greater antihypertensive effect than either drug alone. Another important advantage is electrolyte protection. Diuretics, especially thiazides, can cause hypokalemia. However, ACE inhibitors and ARBs reduce aldosterone activity, helping conserve potassium and therefore prevent diuretic-induced hypokalemia. This improves both safety and tolerability. Finally, this combination has broad applicability. It is suitable for most patients with hypertension and is particularly useful in individuals with heart failure or chronic kidney disease, where ACE inhibitors or ARBs provide additional cardiovascular and renal protection. Beta blockers plus diuretic and triple therapy. The beta blocker plus a diuretic combination is particularly useful in patients after myocardial infarction and in selected patients with heart failure, where beta blockers provide proven survival benefits. However, both beta blockers and thiazide diuretics can adversely affect glucose metabolism. As a result, this combination carries a higher risk of new onset diabetes and should therefore be used only when compellingly indicated rather than as a first-line option. The second situation is triple therapy for hypertension. When blood pressure remains uncontrolled despite appropriate dual therapy, the recommended combination is an ARB, a CCB, and a diuretic. This regimen simultaneously targets the three major mechanisms responsible for hypertension: volume overload, controlled by the diuretic; vasoconstriction, relieved by the calcium channel blocker; and neurohormonal pathways, blocked by the ARB. Combinations to avoid. The first combination is ACE inhibitor plus ARB. Since both drugs block the same renin-angiotensin pathway, combining them does not produce meaningful additional blood pressure reduction. Instead, it significantly increases the risk of renal failure and hyperkalemia. The second combination to avoid is a beta blocker with a non-dihydropyridine calcium channel blocker, specifically verapamil or diltiazem. Both of these drug classes slow conduction through the SA and AV nodes. When used together, their effects are additive, increasing the risk of severe bradycardia or heart block, which can be a potentially life-threatening interaction. Key takeaways. Let's conclude with the key takeaways from combination therapy in hypertension. The first principle is combine, don't double. Instead of maximizing the dose of a single drug, combining two low-dose agents is usually more effective and produces fewer adverse effects. This approach improves both efficacy and safety. The second principle is match to the patient. There is no single best combination for everyone. Drug combinations should be selected according to the patient's comorbidities, cardiovascular risk profile, and tolerability. For example, ACE inhibitors or ARBs are preferred in chronic kidney disease, while beta blockers are reserved for patients with previous myocardial infarction. Finally, avoid redundancy. Never combine drugs that block the same pathway because this usually provides no additional benefit but increases the risk of adverse effects. A classic example is the combination of an ACE inhibitor with an ARB.